All right, well, welcome today. I believe really strongly about how radiology and AI are going to be sort of inherently working together in the future. But today I'm going to specifically talk about the role of artificial intelligence in quality and safety. So here are my disclosures. They're all related to me being a working rad and an executive at Radiology Partners. I'm not selling you anything today. This is purely informational. All right, I think if you're ever going to see where we are, where we're going, you have to look back in the past. And in the past, this is what radiology looked like when I was a medical student. Right? The radiology rooms were alternator boards, and although people weren't sitting on their desks, they were dictating into these dictaphones. And so because of that, no one had access to the images unless they came to the reading room, and no one had access to the reports for days, because it took days for that tape to fill up and for it to come back and everyone to edit it. So what happened was that no matter what rotation I was on when I was in medical school, you may need to mute some people. Whatever rotation I was on, we rotated through the reading room in the morning, and it was so exciting. I was really impressed with the radiologists there who were providing consultations to every single clinical service. I thought they were the smartest people in the hospital, and I was like, that's what I want to do. And what happened during that consultation, it was a very robust discussion between the referring clinicians and the radiologist. And you would get a very robust history, a presentation about the patient, and then the radiologist would take that information in, look at the images, and then provide a consultation back to all of those services. It was kind of like the fun place to be in the hospital. It was like the Starbucks of the hospital. You went to the reading room before you started your day and did anything else. But that was literally back in the 90s. And actually, when I went to residency, my first year, I trained at UC San Diego. And my first year there was 2001. And that year they got PACS. And PACS was great in many different ways. In fact, this is my home reading station, and PACS allows us to read remotely. It allows images to be distributed electronically to anywhere. And also when we got voice recognition, the reports as well could be distributed. And that was great. It also made us more efficient. And I would suggest it made us higher quality. I give a Radiology 101 class to support teammates that come into Radiology Partners to make sure they understand what radiology is. And I give this analogy of us being a bit like the Tyrannosaurus Rex. When you look at an image and you're scrolling through, it's a lot easier when it's laid on top of each other to see pathology popping out. It's like it's moving.
Take off your mask and your hand and your red jacket. Can you see yourself on the TV?
Yeah.
And it's ridiculous. So they'll sink here and then too.
Hey, Dr. Janauer, Murray.
Okay, great. So it's a lot easier to see things as they're moving. It made us more efficient, more effective, and that does affect both quality and safety. And that's a good thing, because between the time where we got PACS in the next 11 years, and this has not changed, here, this is the growth of imaging services just in Medicare. And in that time, imaging services grew 80%. It's like a massive growth. So how quickly did the radiologists grow during that time? 25%. And that difference, really that chasm, had to be sort of managed by something. And PACS helped, right? Because it did make us more efficient. Now we know that this is continued. Growth of imaging is massive. Even if it's not in number of exams, the number of images per exam and the complexity is increasing. And we just don't have enough rads to go around. So this is a problem for today as well. So what did we do in that time? Well, some of it got fixed with PACS, but other parts, well, you just have to read faster. And I'm not talking about reading more efficiently. We were just trying to go faster. And when you try to go faster without being more efficient, you end up cutting corners. It's just impossible to maintain the quality level you could before if you're reading faster. And I think we've all felt this. And so what happens when you read faster and you cut some corners, you just can't do quite as good of a job. And the value that you had created before is not quite the same. Now, we had already lost some of the value, I'd argue, because when we had PACS and voice recognition and people stopped coming down into the reading room, that consultation, that really robust consultation that we had where we provided information back and forth became an electronic communication, whether it is the history that we're getting, which used to be a full discussion from the clinical team, suddenly became whatever would fit in our RIS system. So it was all abdominal pain or trauma, please evaluate. And our consultation subsequently back to the referring clinician became an electronic piece of paper. And electronic communication is not the best way of providing value. So what is value when you're thinking about it? Value in a very simplistic form is just outcomes divided by cost. Now, outcomes may be hard to measure in some cases. Most of it right now is sort of population health based, but you can split that into all of the different components, and quality and safety fit both in that numerator. You can't, I would say, ignore, however, the denominator, that it's important to be able to do this, drive quality, value, outcomes, efficacy, safety, do all of that, do it for the same or even better for a lesser cost. We can't afford to do the kind of healthcare that we're doing now. All right, so the goal, in my opinion, is to be able to use technology to go back to the future. I say back to the future because we would love to go back to the past where we had that robust consultation, but we can't force people to come down into our reading room to do that. Instead of using technology to split us apart, which unfortunately PACS and voice recognition did, let's use technology to bring us back together. And that is possible. And I believe artificial intelligence is going to really help with that. Now, it's not going to help on its own. It's not going to replace us. And I hope you all feel comfortable and secure about that. It's going to be a collaboration between the human and the AI technology, so a human cybernetic collaboration, and also a collaboration between the vendor that's creating this and the data science expertise and us as the clinical experts, whether that is a private practice or an academic center. Those have to happen together in order for us to reach the goal of being able to drive value. So what are we going to talk about today? I'm going to start a little bit with the limitations of artificial intelligence, because until you know and understand the limitations, you really can't figure out how you can manage the quality of a product. You won't know unless you know what it can't do. Next, we'll talk through some examples, and I'll try to touch on the ones that really do improve quality and safety, and there's several. And then I'd like, if we have time, to just talk about what I think might be the future of radiology and sort of this tech-enabled generation. So I would say I am not the only one that's super excited about artificial intelligence. There are venture capitalists that are spending literally billions of dollars in artificial intelligence and artificial intelligence in healthcare because they do think that it can be transformative. And I agree. And although it would seem like that because no one's really making that much money in artificial intelligence, that the venture capitalist funds will be drying up, but they're not. That is still continuing, and it's continuing in a strong way. So if you've got tons of money coming in, certainly there's hundreds of AI vendors out there, even though RSNA was only about 60% the size that it normally is from this past year. There were still over 100 AI vendors that were there. And in general, in normal years, the number of vendors that have been at RSNA has been doubling every year. So huge number of vendors, huge amount of money. Certainly there's some data available. So why aren't we seeing it deployed everywhere? The sense of hype, it should be, right? We're going to go through 7 reasons why we're not. So number one, first, we need to look at what the maturity is of this technology. And although artificial intelligence in some form has been around since the 60s, the kind of artificial intelligence that we're using with deep learning has only been around, it's been around more recently. And so any kind of new technology takes a while to get adopted. And this curve, hopefully you've heard of Gartner's hype cycle. Gartner is an information technology and consulting firm, and this is a curve that tends to work for any new technology, and it's based on Amara's law, that we tend to overestimate the effect of technology in the short run, but we really underestimate it in the long run. So the question is, where are we now? It would be great if we were already all the way at the end, because we'd have everyone using it, but we're not. We're kind of sitting here in the midst of this sort of what should become a supplier consolidation. And we're going to drop down into this trough of disillusionment. And during this time, there's not a lot of adoption. Not a lot of adoption in some reasons, because you could pick a vendor and they might not be around next year. But also the big reason is we just don't have best practices. Things are not plug and play. If you're going to be using artificial intelligence at this point, you're an early adopter and you have to help create those best practices. There's not standards of care for anything, and that just takes some time and effort. Second reason, well, money. We don't have money lying around in healthcare. Some hospitals are barely getting by. Certainly patients can't afford to pay more. So how are we going to manage this? CMS has basically told us they're not paying for it. Anything that they've paid for so far, like the NTAP payment, is a temporary payment. And it's only for a subset of patients where the hospital is losing money. So how are we going to do it? We have to create a business case, and that has to happen before we can have it deployed everywhere. Now, I'll tell you, the first group that came to us, and this was probably 5-6 years ago, they said, oh, great, we have a wonderful business case for you. Our business case is going to be that we're going to replace radiologists. 40% of what you pay is on your rads. And so we'll replace them and you'll save tons of money. And we're like, do you realize you're actually talking to a rad practice? That is not a business plan for us. We're not looking to replace radiologists. We want to make them better, but we also think there's other business plans that can be out there. And I think nowadays, all of the vendors have gotten that. No one's coming to us anymore and saying, hey, we want to replace you. Or even to the hospitals and saying that. They're coming to us and say, well, will you pay us if we make you more efficient? And they're going to hospitals and say, will you pay us if we make you money? And those are effective business plans, but they take a long time to just get through the process. Third thing, artificial intelligence needs a huge amount of data. And we do have lots of data, but it is unstructured. And artificial intelligence does a lot better when data is structured. Our data is also siloed. It's hard to move around. We may think that it's all nice and pretty because we took some time to give a standardized naming maybe to all of our procedures. Maybe we map them to RADLEX codes. But really what our data looks like is more like this. And the bigger you get, the more consolidated you get, the crazier and more variable your data gets. And it's not just on you, it's also on who's sending you the data. I mean, we're finding out all the time that we're getting stuff that's not even compliant with the standards that we have. And even some of those standards, they're older, they're not really helping as much as they need to be. So they're not sufficient to run artificial intelligence. You have to do a lot of work to clean it up before you can get there. All right, the next two things, context and bias. Now, artificial intelligence computers don't understand context. Humans do. And so the only context you're going to get from an artificial intelligence system is something that has been taught. So here's an example. My husband's a huge sports fan, and he, a couple of years ago, went to buy Los Angeles Clippers. It's a basketball team in LA near me. He went to buy season tickets. And after he bought those season tickets, he started getting advertisements on Google for hair clippers. Right? For us, although it's the same word, the context really matters, right? A basketball team is very different from a manicuring type hair care product. And for us, that's very obvious. But for an artificial intelligence system, it's not unless it has been taught. Now, that's true not just for computer vision, but also for natural language processing. So natural language processing tries to understand what we say as humans and sometimes as physicians as well. So if we say Mary had a little lamb, the context that we're thinking, because we were taught this as a kid, is probably the nursery rhyme story. But a context that an NLP system could have, hearing Mary had a little lamb, well, there's many of them. This is just one of them, right? Mary is eating, had a little lamb, a lot of lamb in this case. But Mary had a little lamb can have very many different meanings to a computer system. Here's a few things about bias. There's tons of different kinds of biases that you're going to run across, and I'll mention a few. This one came from something that was pretty famous back in 2016 when it was actually a senior in high school that did a tweet chat. And he went online and he searched for 3 Black teenagers and recorded it. And when he did that search, he got a bunch of images of of people who were going to jail, right? And then he did the same search for 3 white teenagers, and these are the images he got. And it was a bunch of stock photos with smiling, happy people. And if these are the kinds of things that we're seeing from our social media, because they're picking that up, that this is the same kind of thing that can happen in radiology. I did some of my own searches after that because I thought, gosh, this is interesting. I wonder how deep it goes and how we might be able to tie it to other things. Let's skip this. So I did CEOs and secretaries. So I got all men when I looked at CEOs and all women when I looked at secretaries. Then I did one for radiologists, and radiologists I got mostly men, especially when it came to anything interventional. It was all pictures of men. And I did get a sonographer, not actually a radiologist, but the one woman was a sonographer. And if I searched further and went to other pages, I found a breast imaging radiologist that was a woman. So a lot of this information is biased, and it's not because Google is biased. It's because the underlying data that we're using is biased. And that's the same truth that will happen in artificial intelligence. If you have data that's biased in some way, and you might not know how it's biased, then your output is going to be biased in the same way. So here's a couple of examples in radiology. This is actually from a data set, a chest X-ray data set that's public. And someone did an analysis of this data set. And they found that if someone is trying to create a pneumothorax algorithm out of this chest X-ray imaging, many of the pneumothoraces already have a chest tube. And so the bias that's introduced when you're putting all of these and you're saying, yes, this is pneumothorax, the image on the left, and on the right, there is no pneumothorax. They found out that some of the algorithms were picking up on the fact that a chest tube was present. So you're really finding a chest tube detector and not a pneumothorax detector. Really, it should be looking for the visceral pleural line and not for the chest tube. Other areas that they found which have caused some bias are in groups that have different hospital, like in studies where the prevalence of the disease is very different, and that's fairly typical. So here was an algorithm that was being trained on data from a couple of different hospitals, and one of the hospitals had more normal studies, so it had a very low prevalence of pneumonia, and another had a high prevalence of pneumonia. And when they did an evaluation to see, well, what was the algorithm using to make its determination of pneumonia or no pneumonia, they found it was using the label. Now, that's actually really smart, right? The label tells you where the study came from. And if there's a lower prevalence from hospital A and the label's from hospital A, then if you're a smart AI algorithm, you're going to build that in. But we don't want the AI algorithm to be using that. We want it to be looking at the lungs. So nowadays, people are starting to cut out the labels to make sure that doesn't inappropriately bias the output of the algorithm. The two sort of most important areas that I think for me in bias, because a lot of those people know about now and they're trying to resolve for, and it's just about creating a better data set. But this part, a sample bias, what causes a generalizability of an algorithm is how much its data looks like your own data. And what happens with an algorithm where the data is different than your own is the performance is going to be very different. And that's what leads to what we call the brittleness of artificial intelligence. And you could have a pretty good data set, but if your own data is different, even think about COVID coming up. No one talked about COVID before 2019. All of a sudden, we're using that terminology. An AI algorithm that was trained in 2018 would have no idea what we're talking about. So how could data sets be different? Well, the training data might use a different strength magnet. Maybe it is using for a CT scan contrast opacification in a different phase, whether it's late arterial because you have a lot of oncology patients, or more kind of excretory or portal venous phase. That all affects the quality of the output. And actually, the image on the left has oral contrast. It wasn't that long ago where we gave oral contrast to literally everyone in the ED, and now we don't give it to anyone anymore, barely. So was it trained on studies that have lots of oral contrast and suddenly you're not going to have any? Will that affect your algorithm? Yes, it could. Other things are the scanner type that you use and even the protocols and software that you have on that scanner. The quality of the signal to noise ratio and the quality of the study and the different artifacts that are there. the patient population, disease prevalence, all of these things can cause the quality of the algorithm to be very different when it's performing on your data versus the data that was trained on and the quality that they're advertising. All right, and one other kind of bias that is really important to know is that as humans, we tend to fall into what's called automation bias. We really trust automated systems, computer systems that tell us something in an automated way. And so when GPS first came out, that's an automated system, and people started following the GPS and turning the wrong way down one-way streets and driving into parked cars, and in this case, driving into a lake. This was not a hard picture to find. There were tons of them out there, and you'd think, oh, I would never do that. But could we? Could we in when we're using artificial intelligence in radiology, when the AI says that there's no intracranial hemorrhage, that we're just not looking at it quite as carefully? I mean, that's probably going to happen. All right, the sixth component is a much bigger area. I'm just going to give you a brief overview, but it's called orchestration. In order for an artificial intelligence system to get your images, well, those images need to be moved. And then they have to evaluate the images, and then we have to get the data back. So orchestration is really that movement of data. And it looks like this. If you have either images or a report that's going into an AI system, the AI system is extracting some kind of structure from that data, and then it's generally providing it somewhere downstream, usually to the radiologist. The orchestration part are the arrows. How do you manage that movement of data in a very purposeful way? And there's a lot of things to consider. The first part, you need to make sure that you're sending the right data to the AI system. And I'm not going to go through each one of these, but there's essentially 5 things that need to be in there. You need to make sure you're sending the right series of the right study for the right patient to the right algorithm at the right time. All of those things highlighted in yellow need to happen appropriately if you're going to get the quality of output that you're expecting. And I will tell you, when you're talking to a vendor and they say, oh, my accuracy is 98%, ROI is 96%, or area under the curve, AUC is 96%. They are not factoring in any of this orchestration. Orchestration is essentially a way of filtering to make sure that it's picking the right studies. They're giving you a number if all of the exams they get are the perfectly right exams. And that doesn't always happen. Just one example to see what it looks like, because there is an AI algorithm for bone age that's on the internet. Now, it is not FDA cleared, but it's still fun to use. And I took a left-hand x-ray in a child and I ran it through, and it was great. Love it. It won a couple of competitions. It gave me everything I needed, and it did it literally in 1 second. But then I said, well, let me send it a totally different study, like a mammogram, even flipped on end. And it also gave me a result. It told me it was a 13-year-old male. So you have to make sure that you're orchestrating your data to the AI system appropriately, or you'll get results that are not appropriate. Now, your AI vendor may be able to do this for you, but they also might not. Okay, not sure what happened here. Hold on. Let's restart that. Okay. All right, so now the first part of orchestration, you need to be able to manage this. And I will tell you that the current ways we have of managing this, like through our PACS system, are not robust enough. So definitely talk to your AI vendor, see if they can do it. If not, you might want to use a platform or a platform vendor that can do that for you. The second part is getting the AI results downstream. Now, the way that we do that today is we just usually send it to the radiologist through, if it's an NLP system, we send it maybe into their report. If it is computer vision, we will often send a DICOM SR or secondary capture and just put it as an extra series within the PACS. Or maybe you look at something completely external, but the goal is to get it to the rad. And I'll suggest that's nice. That's one way of doing it, but you're losing a lot of possibility if you're not taking where you could send the AI result to. let's say, for instance, there was a CT scan, maybe it was a CTA, and the reconstructions weren't there. Would you want to send that automatically to your rad? No, actually, a better choice would be to send it back to the technologist to say, listen, these other exams didn't come through. Can you do the reconstructions? Or even if the quality of the exam wasn't good enough, you might not want to send it to the rad. Or maybe the sonographer worksheet wasn't attached. You want to send it somewhere else. Maybe you want to send it to an AI algorithm. Maybe you want to do all of those things at once, and you can. So I think you don't want to be limited to just thinking, oh, it only goes downstream to the PACS. If you actually know what is in your data, then you can send it to all different kinds of places. So orchestration means you need a system between your data and your AI solutions, and it has to know something about your data, and that is not necessarily a super easy thing to do. So it can make sure to send to the right algorithm. And then you need one that goes in between your AI to get the output, so you can decide where you're going to send it. The more data you have, the more places that you can send it. And we're going to see this over time, that there are going to be a whole bunch of wonderful context-driven automated workflows that occur by finding out more information about what our data is and deciding to do one thing with it or 100 things with it. I think it's going to be part of the future of radiology. Okay, and last but not least, FDA clearance. I think the FDA has done a wonderful job in trying to manage something that is completely novel for them. They've usually tried to clear things that are medical devices, and now they're trying to clear software as a medical device, and that's a lot harder. But I will tell you that it's not perfect yet, right? If they clear a medical device, does it mean that it's going to work for you in your environment? Unfortunately, no. It may, but it might not. And here's a few different articles that have talked about this. One from the MIT Technology Review. Now, this is just about AI in general. This was Google's diabetic retinopathy model. And Google has done a lot of great things, so it's nothing against them. It's just that what might work and be even FDA cleared might not work in real life in a real clinical scenario. And so you have to understand how the AI is going to work in the context of your own environment and your own workflow, even if it has been FDA cleared. Here's a few more articles where they talk about how you just can't look at what is publicly available in terms of information in order to determine if that algorithm is going to work for you. This was in Nature in April, and here's another one from Academic Radiology just last month, where there's just not enough public information for us to be able to determine how that's going to work, which means that, especially now, you probably have to run a pilot. Okay, so we talked about a bunch of different reasons why AI is not deployed today, and it's really important that you know about them because they all affect quality and safety. With that said, everything that I talked about is manageable as long as we know about it and we're the owner of it, as opposed to trying to kind of sit in the back seat and not know about it. It will be much more of a problem. So if we become the experts in it, just like we have in multiple other ways by working with the artificial intelligence, then we can overcome all of these issues. All right, I haven't really taken a breath, and I probably haven't given you guys a chance to ask questions. I'll pause for a second just in case anyone has any questions about that. You might all be muted. We can...
People want to unmute themselves, or just let me know. I'm happy to unmute you. Or, we can hold questions for the end. Either way is fine.
Okay. Well, I'll keep going on. This is sort of the more fun part, and what are some of the examples that are being used for artificial intelligence in radiology, and can any of them improve quality and safety? My background's in math. I didn't know I wanted to be a physician. I thought I was going to be a mathematician, and I worked on applied mathematics to optimization theory. And when you want to optimize something, you're usually optimizing one variable. And one of the best ways to do that is to split up your work or what you're doing into multiple different segments, and don't try to boil the ocean, say. So people have come to me and they're like, well, what AI algorithm should I make in radiology? How do I improve radiology? It's not the way you want to think about it. You want to break up radiology into all of its different components and think about them individually. And from the moment where a clinician has a clinical question that they need to answer, and the vast majority of time they are answering it with imaging, through scheduling that exam, both with the patient and on the scanner, protocoling the study, acquiring the exams and reconstructing them so we can actually read them, putting them on our work list in an order that makes sense. When you open up an exam from your work list, it will give you some patient information, which again, not nearly as robust as it used to be. We then interpret the exam, which is what most people think that we do all the time. And that's all we do, which is detection, diagnosis, also quantification and segmentation of anatomy and pathology. We then report the exam and communicate the results, and you can't end there because you need to make sure that the patient is followed up when there is follow-up. And of course, we close the loop with peer learning. And every single one of these sections can be aided by artificial intelligence, and it already is. These are different kinds of AI that are being used. Many of them are already FDA cleared, working in every single area that is highlighted here. And the ones in yellow are the ones that we've had the most experience working with, but we're going to go through a couple of different examples, some of which we're using now and some of which we've thought about, so I have more information about for you. So the first one is about reporting. So why did we start with NLP? Everyone else started with imaging and computer vision algorithms. We started with reporting because I think it's, like I said, it's pretty depressing that our consultation is this electronic piece of paper. And that is not a great form of communication, number one. And number two, as humans, we tend to be highly variable. And with variability, variability is the enemy of both quality and safety, and also efficiency. So the more variable we are, then the less that our patients are going to benefit from it. We knew that if we could just improve the variability of our reporting in a way, we could not only improve quality and safety, but we could also probably decrease costs. So we could really drive value. Now, it's not surprising that we as humans are variable. It would take, I read an article, and this was about a generalist, not a radiologist, but it said a generalist would take about 600 hours a month just to keep up with the literature that's out there. Now in radiology, there's so much out there as well. I'm sure it's similar, if not more, especially when you look at artificial intelligence. How could you possibly do that? It's just doesn't make sense to make a human try to do that, but computer systems, it really makes sense to have a computer system do it. So here are just clips of some of the different white papers. Now, there's all kinds of other imaging articles that are available that tell us what we should be doing in terms of follow-up. These are just some of them. But instead of sending them to a person, let's send them to an AI system. The AI system can consolidate that and provide that information to us as radiologists only when it's necessary. You know, the goal in trying to decide what you should do for artificial intelligence is do something that we as humans are not great at. And we're not great at initiating a workflow, so to remembering to do something. And we're also not great at consolidating information from multiple places. So this AI system would be able to do that. Now, we created this system. It's an NLP system. We call it RecOMD. And it's basically providing best practice recommendations to our radiologists while they're dictating, and we integrate that into their workflow. And this exists outside of RP as well. So here's an example of what that looks like. So here is a patient where we're doing a CT of the chest, and we happen to catch the thyroid in there, measure the thyroid nodule, and we see it's 1.2 centimeters. Now, it's an NLP program. It's not looking at the image. It's not looking at that marking that I made up. It's only listening to my report. And it's taking that data along with information about the patient to make a determination. So if I dictate there's a 1.2 centimeter thyroid nodule, it will then give me a result right away. So it's number one, initiating my workflow because it's remembering that there is a best practice out there for thyroid nodule follow-up. And number two, it's looking it up, adding context from the information it has about the age of the patient to determine what the follow-up should be. Now, this is also integrated into the system. So if I realize, I measured that too high, It's actually a 3 centimeter aneurysm. If I then changed my report to say, instead of 1.23 centimeters, right away, the result comes back as a different result. So that contextual integration is really essential when it comes to deploying artificial intelligence. So that system right now works on multiple different best practices, and it will provide the results for that. It also does it for MIPS, right, our macro implementation, and for some billing results, because why should we as humans have to remember that? There's a lot of things that we're going to be building this year that are just completely unrelated to that, because once you have a system that your rads are happy working with, you can add more stuff to it. So automated reference information, when you open up maybe a head CT on a stroke patient from a study that wants you to give the aspect scores, then it can provide the aspect information, or PIOPED criteria. There's all kinds of other things you can do once you have an NLP system that understands how a RAD dictates and what a report looks like. All right, so did this improve the quality of our results? I mean, we do measurements in our practice to see how often people are actually following these best practices. And the first place that we rolled out this tool to, this AI tool to, they were actually doing fairly well. We had 3 BPRs at the time, and they were up above 50%, so almost as high as 75% in their ovarian cysts. And 2 weeks, literally, after we rolled out this tool, their number skyrocketed. And it's not the number that means anything, it's what it means for the patient. It means that they're providing population health best practice recommendations for follow-up for all of these patients that weren't getting it before. So a significant improvement. All right, let's look at another example. Also using natural language processing, because I think it has a wonderful value, and it may be less heard of than some of the computer vision algorithms. So here is an example, a patient, we did an evaluation a few years ago on a couple of our sites, and we had this patient who was 69. He was a lymphoma follow-up, and so he was coming in for a PET CT. And in that PET CT, they noticed a 4.3 centimeter AAA, and they actually reported that in the report. Unfortunately, for whatever reason, the patient didn't come back either for their lymphoma follow-up or for their AAA. And they returned 5 years later, at which point their AAA had ruptured. It had grown to 7 centimeters. And although they worked really hard to resuscitate the patient, the patient expired. And this happens, right? We know most patients with ruptured AAAs don't even make it into the ER. And then when they do make it into the ER, we try to throw everything at it, but the survival rate is not very high. Certainly would be much better if we could make sure that these patients came in for follow-up. Now, we looked back at some other data and found that of the 15 ruptured AAAs that had come into the ER in that time period, 6 of them were seen on priors. So 6 of them could have potentially been followed up and avoided. And we did the same thing with lung nodules, and we found similar in lung nodules. We did an evaluation also on ITN and ovarian cysts to see how often are people coming in for these less critical findings. And it was about 25% of the time people were actually coming in when they should for their incidental thyroid nodules, and only 16% of the time for ovarian cysts. The numbers are even pretty worse if you look overall. So I got this data from a vendor that has been doing this for a while. And out of all of the reports, they say the average is about 15% that have significant incidental findings and need some kind of follow-up. And the problem is if number one, don't mention the follow-up, number one, or you don't mention everything you need for that follow-up, which would be the timeline to do it, the modality in which you want to do it, and the body part that should be imaged. If you're not mentioning all of those components, then 0% of them get appropriate follow-up. So you could be even mentioning, say, follow-up should be done, but you're not mentioning everything about it. None of them are getting follow-up. And for the ones where you do mention everything that's needed for that very specific follow-up, still there's only a small segment of the population that's actually getting followed up. So out of all the tests that should be ordered, there is a significant amount that are of follow-up studies that are being missed. And this is not unexpected. It's a care coordination problem. We as radiologists feel like we've done our job when we've provided the appropriate care, and we're going to do that in the 40% of the time. But it's very hard for that information then to get to the referring clinician and make sure that not only do they order the study, but the patient comes in for the study. And if the patient doesn't come in for the study, that follow-up reminders are there. So this is a perfect place for an artificial intelligence system. And some of them are already doing it. And here's what it would look like. So you find a radiology report. It would use natural language processing to find any time where you're recommending some kind of follow-up. It would put that into your AI system, and then your AI system would pass that downstream to where clinical care is happening at the hospital. Maybe that's a nurse navigator. If they've got a lung nodule follow-up program, it would go to that group. But the idea is that you want to provide access to this information in a cohesive way. And we've done that at our practice. We would provide them with an electronic mechanism to monitor their follow-up. There are AI companies out there that are even going further. They are taking that information and integrating it with the EMR. So instead of the referring clinician having to make sure that they see the report, they just go into their EMR where they live. And if their EMR, the EMR will have the information, and they just get they can click the follow-up and schedule the exam right then. These different groups are also connecting with the patient. I think that's important these days. You have to make sure that the patient knows that they have something to follow up on, because they might even be better at taking care of themselves than it is for a system to take care of them. So they'll have ways of communicating with the patients, just like we do with breast imaging. And then they can provide analytics, and these analytics can help confirm the ROI for the system. It can make sure that we are really driving value and improving patient care. Okay, last one I'm going to talk about is Triage. Now, this is a computer vision algorithm. And I'm going to talk about this because it's probably the most common computer vision type of algorithm out there. And it's essentially a detection. It's a detection algorithm that goes in and looks for certain kinds of critical finding, depending on the algorithm. And then it will alert the computer system, your work list system, that there is a critical finding and move the study. So what does that look like? If this is your work list, all of these studies would get sent to your algorithm. Your algorithm would identify the ones that have critical findings, and then they would get moved to the top of the work list. So instead of organizing things simply by the priority or the service level objectives that you have to meet for turnaround time, you can organize it by pathology as well. And a lot of people were kind of like not that excited about this in the beginning. I wasn't even that excited about it. I'm in the part of the division that I'm in with the radiology partners. We read mostly stat exams. So if I read it in 15 minutes or 20 minutes, is that going to make a difference? Like, not really, unless it's a stroke case, in which we're reading it fast anyway. So how much of a difference is it really going to have? Maybe with your inpatients, for sure, you might not get to those for maybe 1 or 4 hours, or your outpatients where you might not get to them for 1 or 3 days. But the amount of critical findings that you're seeing in that population are less. So I just wanted to let you know that we did a pilot, 6-month pilot with 2 different CAD triage algorithms, and we found that there were actually significant benefits. So let's go through those. So number 1, the CAD found pathology we were missing. So we did one for for pulmonary emboli and one for intracranial hemorrhage. And we found that we were missing studies. So about 4.4% of the positive PEs were being missed, and about 2.4% of the intracranial hemorrhages that were being missed. Now, the examples just below the numbers, those are actual examples of missed cases. So the one with the PE, it is more in a typical location because it's in the lower lobe, but it was solitary and subsegmental. And a lot of the other ones that were being missed were distal and often in the right upper lobe and solitary with nothing in the lower lobes. The one on the bottom right, which is the head CT image, super subtle, especially the ones that are hitting up against the calvarium. They're just so hard to see, even when you change your window levels. And people are missing those really subtle intracranial hemorrhages there, and maybe sometimes also along the falx. So the question that we should ask ourselves are not just, hey, yay, great, we're detecting more pathology. We don't want to just detect more findings. We want to improve quality and we want to decrease cost. And you could imagine a case where if you treated every one of these PEs, that you may have more complications or more costs to the system than you get benefit from it. Or if you put all of these patients with these subtle intracranial hemorrhages into the hospital, you could be increasing your costs and for patients that don't really need it. So should we even care about these super subtle misfindings? I will tell you, this is an area that we need to concentrate more on. The goal for us is to be able to look at the outcomes of these patients to see which are the patients that we do need to keep that have these subtle findings and which are the ones, or treat, and which are the ones that we don't. Is there anything about them that we can help tell? Because you can't ignore them, and here's why. So here's a 72-year-old female that came in with altered mental status, no history of trauma, was not on Coumadin, and there was a really small left-sided subdural that was missed initially. We ended up calling the ER and calling the patient back. They came, when we were able to get them back in, it was 36 hours later, and this is what the hemorrhage looked like. So massively increased. And even though the patient had volume loss, being 72, the size of it was causing compression of the left lateral ventricle, left to right midline shift, and they were symptomatic. They actually had to have a craniotomy. So just because a finding is super subtle does not mean that it's not relevant and not going to grow. So what we have to do is figure out, how can we use AI to help us triage which are the cases that we should keep and treat or follow, and which are ones that are okay to go home. Last thing is that unless your rads like the tool, there's no point in doing anything about it, because clinical rollout is much harder than technical rollout. It's a change management component, and it's also about education, because these are clinical tools and we need to educate our rads how to use them. We did an NPS score, which, if you haven't heard of an NPS score, is just a single question where we ask a rad to grade from 0 to 10 if they would recommend this product to a friend or colleague. And a grade of 64 is actually quite high. It's above Amazon even, so people really like the tool. And that's important, again, if you're going to roll it out. Last thing that we found is that since we were rolling it out sort of for a part of our practice and not everywhere, we found out the value that AI could have in peer learning. And instead of reading through any of this, let's just look at an example. So in chest x-rays, the miss rate is reported up to 40%. Not that we're missing giant things all the time, but we are missing something. And so let's use a 20% error rate just for visual. And let's say now I have a bunch of chest x-rays. So here's 190 different chest x-rays. If my error rate is 20%, then I'm going to have 38 chest x-ray errors. So everything in red is a potential miss from a radiologist. Now, if you're doing peer review, now a lot of people do 3 or 5%, so let's just start with 3%. If you're reviewing 3% of cases randomly, out of that 190 cases, you'll review 6 of them. And out of those 38 errors, you will statistically find only 1. So what does that look like? Here's the 6 cases coming in, and only 1 of them should statistically overlap with one of these potential learning opportunities. Here's what it looks like. Here's your learning opportunities. There's 38 of them, and here's how many you would find. And we know that that in peer review, the kind of peer review we're doing these days, where it's used against you in many ways, the rads might throw this back. If there's an error, they might say, I'm not going to put this through peer review. So you might get 0 learning events. Now, even if you're doing 5% random review, you only are finding 2 of these. Now, let's contrast that with artificial intelligence. Now, right now, artificial intelligence is only looking at a few things, but there are already algorithms out there that review up to 124 findings on a chest x-ray. And there's one coming out this summer that is going to find 60 findings in a head CT. So over time, the number of findings is going to be more robust. But let's just start with this. Now, AI can review 100% of the cases. You don't have to pick or choose. The sensitivity is not going to be perfect. So let's say it's 95% sensitive. So here's our 38 chest X-ray errors. We're going to review 100% of them, but we'll only catch 95% of them, which gives us 36 AI enabled learning lessons. And think about what you can do with that much robust information. It's a wonderful way to educate your radiologists, to educate residents, to do continued education over time. My first job was with a telerad company. And so 100% of my studies were overread. I learned more in that first year than I learned any other year of my career. It's really a wonderful way to learn, and AI can help enable that. All right. There's another reason why we should be educating our radiologists about artificial intelligence. We have to remember that AI is not just an IT tool. It's not a PACS upgrade or a VR upgrade. AI is a clinical tool, and we need to educate our radiologists about how to properly use it. Just like when MRI came out, and when MRI came out, people said, well, we're not going to need RADs anymore. MRI is going to show us the pathology so easily, anyone will be able to look at it, right? It sounds very familiar. Well, they're saying the same thing in AI. So why do we read MRs today? We read MRs today because we took the time to be the clinical experts. We learned about it, developed expertise, and with that, people came to us when they had questions about MR, and we could answer them. We need to do the same thing in AI. If we do that, we could take the driver's seat in a technology that really doesn't know yet where it's going. It needs clinicians to drive where it goes to make sure that we do the best things for patient care. Now, we could consume it passively, as opposed to actively become the expert, and then we're sitting in the back seat, but someone else drives where we go. Or we could ignore it completely and have the car drive over us. But I would argue that both of those would be a disservice to our patients, to our profession, and to healthcare overall. So I think it's really important that we take the time to take this early learnings that we get. I mean, there's more AI that's out there in radiology than in any other specialty. Take the time to learn about it. Don't be afraid of it. This is going to be part of our future. If you embrace it, then you can help drive where it goes, and you can really help us as a profession make sure that we do the best for our patients and our clinicians. So take that time to become the early expert. Now, we're doing this in our practice. We have a cloud native system where we have AI that's available. Right now, we have 15 million, both images and reports annually that are available to this cloud system. They get evaluated, both of them, by the AI system. It reads the report and also looks at the image. And if there's a discrepancy between what the report says and what the AI says, then that information is passed on to a peer learning system that we use to educate our radiologists. Now, it's a discrepancy. It might mean that the AI finds something that the RAD didn't, but it also might mean that the RAD found something that the AI didn't. And both of those are equally important if you want to educate your radiologist about how to properly consume AI. We also pass that information back to the AI system. Now, we've got 15 million images available now. In the next couple months, we'll have 20 million images available. And that kind of amount of data going into a peer learning system where you're teaching your radiologist about how to work with AI, where is it right, where is it wrong, how do you get better by using it, that's what puts us in the driver's seat. And I really want to encourage everyone to try to do the same. Okay, one last use case and we'll be done. This one's kind of a fun one. It's completely separate from this area. There's use cases outside of AI, and that's in managing our data. Our data, as you know, is unstructured. And how can you add structure to it? Well, let's take a look at it. So here's our unstructured data. What do we do now in order to tell what's in our data? I mean, unless you have a RAD or physician reading the report, or if you're having a RAD look at the exams, there's not that much structure that's in them. Well, we have standards, and we use DICOM and HL7. So DICOM that will tell us about what is in the image, and HL7 tells us about what was ordered and what was in the report. And there's some structure in that, a set way of doing things. And with that, you can get some data about the patient or the exam. And so I pulled some of those out and showed them visually as these blue ovals with information. It's a way of adding structure to our unstructured information. Now that's great because it's the only way we kind of have right now. The downside is that, number one, the data is not always right. In fact, you may be using the HL7 order to know what's in your DICOM. And if the study was performed different than the order says, then they're not going to be the same. Maybe there was contrast that was supposed to be administered, but it extravasated. So the study was a CT abdomen pelvis with contrast, but ends up it's not contrast because it extravasated. Or maybe they tried to get 3 views on this hand x-ray, but they could only get 2. So the data is not always accurate. The second part is you need lots of humans to manage the system, which is just craziness. Why we have humans trying to manage what a computer system could do better is nutty, but every single group will send you DICOM and HL7 in a slightly different way. And so you need humans to do mappings and make sure that everything is congruent. Now, what could you do instead? Well, here's a better way. What if you use artificial intelligence to either read the report using NLP or look at the images? Number one, you could get a vast amount more data than you would by just getting it from DICOM or HL7. You could look at the quality of the study. You could actually look at the image and know if it was a 3 view or maybe it was a 2 view. So you can correct some of the information that was wrong either on DICOM and HL7. The more information that you get, the more things that you can do in your workflow. So I think AI is a fantastic way to actually manage and add value to your data. And I think that we're going to see more and more of this in the future, or at least I hope we will. All right, let me finish up because I know it's late with just the last couple of slides on where I think radiology is going to be in the future. I think that it's important to remember what Steve Jobs says, that if you don't cannibalize yourself, someone else will. We've done that a lot in radiology. We redefine ourselves. And so this is, to me, is sort of what a rad could be like in the future. Now, ignore that it's Tom Cruise in Minority Report, but imagine that Tom Cruise is a radiologist and he is reviewing a massive amount of data. We're going to have information not just from the imaging itself, but we're going to have molecular imaging, we're going to have radiomics and genomics, and we're going to have information from artificial intelligence. All of that has to come together in one place. We have to be able to take a look at it and understand where it's right or wrong, make changes to it. And as we make changes to it, that data has to get reprocessed within our system so that we can add the context and provide that back to our referring clinicians and patients. I think the radiologist in the future is not just going to be the imaging expert. I think we're going to be the information expert. Okay, so with that, today we talked about some of the limitations and applications of artificial intelligence and how it can affect quality and safety in practice. We also talked about the importance of educating our radiologists about artificial intelligence. They need to be the experts. We need to be the experts if we're going to drive this technology to help our patients. And last, we talked about the idea of radiologists as the information expert in the future.
Nina, thank you so much for such a great talk. I mean, I could not agree more with you that probably AI is the new modality in radiology, and maybe we're going to end up having an AI fellowship in a couple of years from now, similar to we have CT or MRI or any other subspecialty training in radiology. With this, I'll open it for questions, and Susie will be doing the Q&A.
Yes, I just wanted to echo Danya's sentiments in that it was an excellent talk, and thanks very much for coming tonight. I was just wondering, before we get started with the question and answer section, if you might comment a bit on the ethics of AI and some of the challenges from that perspective.
Yeah, there's a few different areas when you talk about ethics. Some of the ethics is just making sure that the algorithms are free of bias and available to populations that need that. And so part of it is looking at the data and making sure that the data is as generalizable as possible, or that it's appropriate for that algorithm. And that has not always been the case. So that's one component. The second component is about data and who should have access to it. There's a lot of discussion about Who owns the data? In Europe, that's very simple. They've been very clear about that. The patient owns the data in Europe. In the US, it's much more complicated. It's not even a federal law. It's a state-based law, and it's different state to state. And I think it's only 2 places, maybe Vermont and one other place, where the patient owns the data. Everywhere else, the data is actually owned by the group that performs and stores the study. So then you have to ask the question, well, am I allowed to use this data even if I don't own it? Is it ethical for me to use it and create more, create products from it? Can data be sold? There's a lot of discussion about that is out there in the literature. I will just give you my opinion. I believe strongly that the data that we're using on its own, its primary case is to treat the patient. And after that, that data should be used for the benefit of the population. And I believe strongly that that data should not be sold. And if you are going to do anything where you want to sell data, you should only be selling anything that you provided, you put effort into creating additional information about. And so there's all of these questions, but it's a very, a short answer to a very long problem, but I just wanted to give you at least a bit of an overview.
Thank you.
So there's a few questions in the chat.
I know Rebecca had her hand raised as well.
Okay, sure. Why don't we go with Rebecca?
Hi, Nina. Thank you for that excellent talk. I have 2 questions. One has to do with the NLP that you showed in reporting, where it brings up the recommended best practices based on findings. How structured does the way that you describe that thyroid nodule need to be? If you don't use the word nodule, or if you say nodule in the thyroid, does it still work? My second question is, you talked a lot about the sensitivity of AI for small subdural hematomas and pulmonary emboli, but not about the specificity. And do radiologists complain that they spend a lot of time reviewing things that AI has found that turn out not to be real findings?
Great questions. So the AI we created and we use internally, it's actually very good. We wait till it gets to a certain level of accuracy before we roll it out. And that accuracy, we like it to be at 95%. So NLP is different than keyword search. And what a lot of us are used to, and what people used to call AI or sometimes call NLP, is more keyword search, like you're saying, that has to have a certain keyword in there. And that keyword has to be within a certain number of words from another keyword. So that when you say there is a thyroid nodule versus there is no thyroid nodule, if the negation is close to the word, then you know it's a negation. That doesn't work that well because we are complex as humans and radiologists, and we dictate in complex ways. We actually did a study on AAAs. We looked at, and this was many years ago when our practice was much smaller, but we looked at how many ways did a radiologist say that there was a AAA, and there were about 55. And then we looked at how many ways a rad said that there was no AAA, and there were over 115. So you could never create a keyword search that would help you find that. So NLP is different. It tries to understand the meaning of the wording, and it tries to put multiple sentences together to understand that. I think where it has the most trouble is when you dictate something over multiple sentences and you're not tying them together. So the easiest thing it could do is say, well, there is a 4 millimeter hypoechoic nodule in the right lobe of the thyroid gland, or hypoattenuating, depending on what imaging you're seeing it on. But you could also say that is, there is a nodule in the right lobe of the thyroid gland, period. The thyroid gland is enlarged. The left lobe is heterogeneous. The nodule is 4 by 3 centimeters in size. And then you could describe it over multiple sentences. That's really hard for NLP. So it does not do as well when you're very verbose in how you describe things. The other thing that NLP is not good at is it's learning natural language. We don't speak in natural language. So especially when we're using very structured reports where you just say thyroid colon normal, or thyroid left lobe colon normal, right lobe colon nodule, that's much harder because everyone can be dictating it in a very different way. So in general, ours is very good because we've trained it on a lot of exams, but you have to be aware of how NLP works, and there are deficiencies. The second question that you asked was about the specificity. And are you going to get, like we do with CAD, where you just get a lot of false positive markings? Great, it's hugely sensitive, but you're wasting all of your time with false positives. That's a huge issue, and you have to make sure the sensitivity is also high. I will tell you from the AI that we've worked with, which have been we've done about 10 different kinds of algorithms we've looked at. And in all of those, we're testing it specifically for that. And the ones that we choose to deploy are the ones that have both highest sensitivity and specificity on our own data, because you don't want to waste a radiologist's time. And I will tell you, in that evaluation that we did for CAD-T for both of those, the RAD reading time decreased by 11% for intracranial hemorrhage and 12% for PE. And that was not because of the positive cases. That was because the RADs trusted that when they said it was negative, it really was negative. And so RADs went faster overall. So you do have to look at that. It's not going to be the same for every algorithm, but for the ones that we're looking at, there are plenty that are out there that are very specific.
Thank you.
We have a couple of questions in the chat too. It looks like one viewer asked, where are we with AI for breast imaging? Is any company using prime mammograms as comparisons to look for changes?
Yes, there are probably 5 different groups that have FDA cleared algorithms for breast imaging, both for triage, normal, abnormal of screening mammograms, and also for detection of pathology. And many of them look not just for masses, but also suspicious calcifications, asymmetries, and architectural distortion. There are fewer, but many of those same groups also are doing the same for TOMO 3D. And there are probably 3, maybe 4 that have FDA, I think 3 that have FDA clearance right now, and a few that are pending. And some of those are quite good. We're going to be trialing several of them this year.
Another viewer also asked, at the beginning of the talk, the need to increase speed to match increasing volume was mentioned, with the challenge of being how to do that while still preserving quality. The AI examples demoed showed the improved quality aspect, but any examples of AI directly increasing speed, i.e. pre-filling radiology reports, making comparisons, pulling findings from prior?
Yes. We're looking at more of that this year. Last year, we looked at things that would, number one, improve quality, but also sort of drive a business case, because you have to figure out what the business case is going to be if you're going to get anyone to pay for AI. But now that we just don't have enough RADs to go around, we need to look at things that improve efficiency. So a lot of the algorithms will. You might not think they would, but again, that CAD-T algorithm, which we did for intracranial hemorrhage and PE, they increased our read rate by about 10%. And that's because if they are sensitive enough for your findings, then when they say, or their negative predictive value is high enough, when they say the study is negative, then you could feel more confident about it. And when you think about any kind of pathology, a detection for pathology, most studies are normal, right? The incidence of intracranial hemorrhage is about 5% in our organization, about 7% for PE. So if you improve on only 5 or 7%, you're not going to change your overall reading rate. You have to improve on the 93 to 95%. So you really, any algorithm that's going to speed you up is speeding you up because the normals are making you go faster. Also, some of the triage algorithms, when you triage all of the normals together, whether that is the screening mammograms or TOMOs, you put all the normals together, people can go through those very quickly. They're coming out the same with chest x-rays, where it's hopefully will be soon FDA cleared in the next couple of months, where an algorithm will triage all of the normals together and you could go through them quickly. Also, some of the things that you mentioned are great, using NLP to pre-fill out some information. Some of that doesn't even need NLP. Some of it can use some basic information from the packs to just pull up what you're looking at in as a comparison, make sure all of your comparisons are in there. But certainly the AI system that I was talking about that would look at the images, could look at the images and then pre-fill out your technique. So absolutely, there's some of that, and I think it's important to look at.
Let's see, Dr. Maiden has his hand up, and then we can go back to the chat as well. May I unmute you? There we go.
Hi, yeah, thank you so much for this great talk. I guess, when you say that, I see the huge value in being able to kind of create efficiencies, especially for attending radiologists. But since I'm program director, I'll pose this question to you, and maybe this isn't quite up your alley, but to what extent do you think we have to be careful about when we're training radiologists about making sure that they actually go through the process of kind of reading it on their own before exposing them to some of these technologies, and how that might affect the training for residents?
Yeah, I mean, the only way where an AI system works better with a radiologist, if the radiologist understands how the AI system works, but also understands how to read the exam themselves, because you can't figure out if the AI is right or wrong if you don't know how to read the study. And like I said, there's no standards yet. We have to define them. But I think the ways that you could think about, number one, remember that our future is going to be integrated with artificial intelligence. In every mechanism. It may seem weird now because it's new, but just like PACS when it first came out and we're like, oh my God, I could never use PACS, or I could never use VR systems. Now it's like nothing, right? This is what it's going to be like in, I don't know, it might take 10 years, hopefully not that long. But yes, if you want to educate your residents, you need to educate them about a few things. You need to educate them about how to properly read an exam, because you don't want them skipping things just because they think they're relying on the AI through an automation bias. Number two, you could not have the AI produce them the results real time. You could use the AI either in the background or only if they don't mention something. Or you could have the AI results only be visible after they finish their report. So there's all kinds of ways that you could try to manage that and see what works best for training. We don't know yet what the best way is. We do know that we're biased creatures. And so if you show us the AI results first, it's going to bias us.
Thank you.
So we'll take a couple more questions. Oh, Jennifer actually has her hand up. So,
Nina, hi. Thank you so much for being here with us. I miss seeing you nationally, and I will look forward to the next time that we get to catch up. And thank you for your leadership on all of this. Really, nationally, it's really been profound, and the effect that RP's had on sort of moving us all forward. I have so many questions. I'm going to sort of follow up on Neil's, though, about how to make certain that radiologists have the appropriate skills and that we avoid our own bias. So when you talk about batching normals together, how does that not sort of create bias within the radiologist who's reading them and just presume that it's all normal without really using our usual thorough search pattern?
Yeah, the goal is for the AI plus the radiologist to be better together and not just to be fully trusting the AI. I think people start off initially not trusting a system. But what you can do with these AI systems is they're basically, you can set the sensitivity and specificity along a curve. So everyone talks about what is the area under the curve. Oh, my AUC is 96%, but that's choosing a specific level of sensitivity and specificity. So if you wanted, you could choose one where the algorithm was so specific to it being normal that pretty much 100% of the time you're going to get normals. Now you're going to have a lot fewer cases and there'll be a lot of normals within your abnormal section, but you can set that sensitivity and specificity level appropriately, what's based on your organization. And then you change it over time. Because you're right, you have to learn, you have to have the radiologist learn how to work with the AI system. And this is where I speak a lot about how everyone thinks the clinical rollout is just nothing. The clinical rollout is the toughest part. It's not because it's hard to understand AI, but you have to teach people about where the AI doesn't work so that they can oppose some of these biases and not just automatically go down this pathway. And you also want to teach radiologists about things they're missing, which there's been wonderful learning lessons we've had already, and just upscaling the radiologists to be better at what they're doing. So I think you have both sides. You have to be careful on the downside that people don't just automatically go by the AI result. And you do that through education. You do it through showing them cases where the AI makes mistakes, because AI is frozen at a point in time. It's machine learning, but the FDA is not letting it machine learn right now. So if it makes a mistake on one case today, going to make a mistake on that case tomorrow. So make sure your RADs understand where it will make mistakes. That's the only way that RAD plus AI get better together. And that's what helps prevent some of that bias. Now, on the other side, you have also learning where you're upscaling the capabilities of your radiologists, because you're showing them all these kinds of cases that we tend to miss. And I think that's wonderful. So you need to do both sides, and you get a plus and minus, but the hardest part is absolutely educating the RADs.
I'm going to follow up with one other question that's very helpful. Thank you. And as you're talking about it being a heavy lift for a rollout, you're coming from the perspective of a pretty large organization that's heavily resourced and has a lot of experts in this arena. The beauty of this group is that we have a mix, right, of large institutions that are represented here, but also we have some very small private practices that are attending tonight. And I'm hoping you can address the needs of a private practice, a small private practice, as they consider doing this, which would be very different from a large institution.
Yeah, sure. Actually, interestingly, we're large, but when we started small. I gave a lecture about governance at RSNA. They still have it up if anyone's interested in learning, like, what do you need to do in your organization to manage artificial intelligence? And what I said was, at the beginning, it was just part of one person that was doing everything, because we didn't know if any of this was going to work. We didn't invest tons of money right away without doing any kind of trials. So we started really small. The reason why I know everything I know is because I've been there since the beginning. That was me at the beginning that was trying to manage and learn all of this. So you can start small. I think if you are a smaller organization, you have to rely more on the vendor. And vendors these days are really interested in working with you. They're trying to prove their business case. They want more people to be buying their algorithm or to trialing their algorithm and writing papers, or even just to say that, oh, we deployed it at this site, and the site is a small site that is rural. And guess what? The accuracy was wonderful there. They would probably do a lot of the analytics for you. So you don't need to have a huge amount of dollars and people behind it. You can start small and just get help from the vendors.
Thank you.
Sure.
Well, it's just about time. So I wanted to echo Jennifer's sentiments as well, and thank Nina for her talk tonight. I think it was really amazing. I learned an awful lot myself. I don't do a lot of AI myself in general radiology, but it's just fascinating. More questions than when I came into the presentation. So thank you very much. I think Danya mentioned our next meeting is going to be in the beginning of April. If anyone has suggestions for speakers or topics that they'd like us to cover, please reach out. We're open to suggestions at this point. And if not, we will review our notes and see. And I'm sorry we didn't get to all the questions in the chat. But thanks everyone for coming tonight, and thank you, Nina and Danya.
Thanks for having me. Get involved. It's really fun.
Terrific. Thank you.
Bye.
Thanks so much, Nina.
Thanks, Nina.
And thanks, Danya and Susan, for organizing.
Of course.